Okay, everybody, recording. Okay, to epidemiology seminar. So I'm very glad to have in-person speaker here today. And I'll start with land acknowledgements. McGill University is located in traditional and unceded territory of diverse indigenous people, including Haudenosaunee and Anishinaabe people. And I'd like to thank their presence, which shapes the land we exchange today. So I'm very glad to introduce Dr. Marie-Pierre Sylvestre, who is Associate Professor in ESPAM, École Sainte Publique Université de Montréal, and also investigator in SHRM. So Dr. Sylvestre is also FRQS Junior 2 scholar and research on natural history of cannabis use and cannabis use, as well as cannabis-related substance-related disorders. And she's also a co-PI of the ongoing nicotine dependence teens study funded by CIHL and FRQS. So she will today discuss about her research on perceived access to cannabis use. So please go ahead.
Thank you. Oh, there's a way there. No, it's there. Okay, so I'm gonna stick in the middle. Okay, that's good. It's better if I get to see people.
Thank you. You can lower this table if you want.
Oh, that's fine. That's fine.
That's
fine. Thank you. Well, thank you for the invitation. It's a pleasure to be here. When I was preparing my talk, it just reminded me how things don't change. When I was a PhD student here, I was modeling benzodiazepine use, and now, almost 20 years later, I'm modeling substance use. So, I mean, it's gone from legal to somehow illegal in kids, but it's still modeling some sort of substance use over time. The work I'm going to present today is joint work with several students on my team, as well as colleagues from ESPUM, Isabelle Doré and Jennifer Lockton, and colleagues from the COMPASS study, which I will use throughout my presentation. So Richard Bélanger and Slim Haddad at Université Laval, who are the PI of the Quebec part of the COMPASS study, and Scott Lauderdale, who founded the study a few years ago. So I declared I have no conflicts of interest. And today I will give you a portrait of cannabis use in youth, and then I will discuss the natural course of initiating cannabis use in youth, including risk factors and the mechanisms that we think underpin the initiation of cannabis use. I will present results from the COMPASS study, and I will discuss harm reduction strategies, and especially a prognostic tool that my team developed to identify youth at risk of regular cannabis use. And I will finish with the question and answer period. So a few words about the cannabis use in Quebec. Yep.
Sorry, I don't know when it's. Sorry, go ahead.
Okay, thank you. We're lucky in Quebec to have the Institut la Statistique du Québec have a representative survey that is conducted yearly on cannabis use. And so because of that, we're able to see that since cannabis use, non-medical cannabis use was legalized in 2018, the prevalence of past year use has slightly increased in all people aged 15 and older. If we look at youth specifically, they only record data for people aged 15 to 17. The prevalence of past year uses has decreased slightly, but it's still more than 20% of adolescents aged 15 to 17 who report using cannabis. Now, when they're asked about their sources for getting cannabis, most youth report having cannabis from family, friends, and acquaintances, some from the illegal market, about 20% of purchases. And interestingly, 16% report getting it from SQDC, which is the legal way to buy cannabis in Quebec, although it technically is only allowed for people who are 21 years of age. So that's an interesting finding. Also, interestingly, when asked about their perception of the risk associated with using cannabis, adolescents aged 15 to 17 say that half of them say it's moderate risk, 42% say a high risk. So there's this perception that cannabis use is somehow risky, although this is just one question and it doesn't get into the details of why they consider it at risk. The mode of use of cannabis is still mostly through smoking it. Interestingly, however, now we see more and more people reporting vaping cannabis, and it's very much related to age. In the younger generation, 15 to 17 again, it's 73% of people who report having vaped cannabis in the past year. While if you look at all ages combined, it's roughly only 24%. And one of the reasons why this is an interesting finding is that there doesn't seem to be a great knowledge of what people are vaping. So again, if you look in the younger generation, according to this survey, which is representative of the Quebec population, 44% of vapors actually know the THC content of the products they use. Now, THC is the psychoactive ingredient of cannabis. This is what gives people a buzz. This is what also can create some addiction. And among vapors who know how much THC content their product has, 50% use cannabis products with only THC in it or more THC than CBD. CBD is a non-psychoactive component of cannabis and is not associated with dependence, although it can have its own effect, especially apparently on pain or inflammation, although this is not fully supported by the literature. Now, this is quite interesting because the cannabis that was around, let's say 30 years ago, is not the same products as we see today. And on this graph, you see what the DEA, so the body in the United States that actually sees or control police cannabis, seized different products throughout the years. So you see it goes from 1995 to 2022. And the content of these products for CBD in blue, it's been very stable over the years, but the content of THC in cannabis products that were seized over the years is rapidly and constantly increasing from 4% roughly in 1995 to more than 15% in 2022. So the products that we see today are more potent, they're more likely to be addictive. And so when people do not know what they're vaping, it's likely that it's perhaps more THC than they thought they'd be getting. Okay, so we have a pretty strong literature on the mental health aspect associated with cannabis use. This literature is robust. It comes mostly from longitudinal studies. And here I'm reporting results from various meta-analysis. So first of all, we know that for a psychosis, we know that there's an association between using cannabis and using cannabis regularly with the development of psychosis during youth. It's an association that has a dose-dependent relationship. So the more cannabis you use, the more likely you are to develop a psychosis. If you use cannabis early on, you're more likely also to have an early onset of a psychotic illness. If you use it frequently, also it's more it's associated with higher risk. Now, granted, the risk of psychosis is relatively rare. It's like 3%, I think, the lifetime prevalence, but it's a very severe condition to develop. So this is obviously something that has people concerned. There's also quite a bit of literature on the association between cannabis use and mood disorders, including depression or depressive symptoms, anxiety, and associated with that, suicidal ideation and suicidal attempts. Here I'm showing you meta-analysis from 11 prospective studies in adolescents. And here you see that the association between cannabis use and depression is quite precise. And the I-square that represents the heterogeneity and the across results is very low. So I think this is something that we do see in the literature, regardless of the study. The relationship between cannabis and anxiety is a bit more difficult to pinpoint. It really depends on the time frame over which you measure it, because anxiety is known to be associated with cannabis use in the short term. So people will often use cannabis to alleviate their symptoms of anxiety, and sometimes it will work. In the long term, however, there is literature saying that anxiety will be building up if people use more and more cannabis. And similarly, suicidal ideation and suicide attempts seem to be related with cannabis use, although the literature here is less precise and a bit more difficult to interpret. Now, I should say here that it's quite important to look at longitudinal study, because as with other substances, we know that we know about the biological, at least some of the biological mechanisms that explain why using cannabis can lead to increased symptoms of depression or anxiety. But we also know that people tend to use cannabis to self-medicate for depressive symptoms, for anxiety. So there's this bidirectional association that might sometimes be quite difficult to pinpoint. Now, in these studies that I'm showing you, some of these studies were able to capture the onset of cannabis use, which helps a bit differentiate between one side of the association from the other. And finally, it's quite important to mention that cannabis use is also associated with increased risk of accidents, for example, when driving under impairment while impaired, and also is associated with problems with school perseverance and cognition. Although according to the literature, the problems associated with cognition tend to disappear when people decrease their use of cannabis or quit altogether. Age is extremely important in the understanding of the impact of cannabis use on adolescents. And this is something that I think everybody knows now, because it was highly discussed when non-medical cannabis use was legalized. This idea that the adolescent or the adult brain only fully develops when people are roughly 25 years of age. And what we know at this point is that during adolescence, cannabis will have an impact on roughly two important parts of the brain. I'm not summarizing a very vast literature here. I'm just trying to pinpoint two of the major findings that this literature brought in the last years. The first one is that THC, which is the psychoactive component of cannabis, it alters the signaling within the endocannabinoid system. Now, this is important because this is a system that exists in the brain to regulate the development in the brain of reward and stress circuits, and it's associated with pain. So while this is developing during adolescence, there's this interference with THC that can cause actually structural but also functional changes in the brain. There's also this other finding, and there was a paper published very recently that regular cannabis use is associated with structural changes in the brain. Namely, it affects the cortical thickness in the frontal lobe of the brain. Now, this is, in a nutshell, where the systems for planning skills and decision-making is situated, is located in the brain. And there's more and more findings, both in humans, but also in animal models, saying that these structural changes could be long-lasting and could have impact on planning skills and decision-making. Now, there's also quite a bit of literature that suggests that regular use early in adolescence, so before the age of 15 years, is an aggravating factor. So it makes these the impacts that I explained on this slide more important, more severe. So if you look at different strategies that were put together, let's say by the Pediatric Association in Canada and other associations like that, the strategies for harm reduction are basically twofold. The first fold is really to try to prevent and delay cannabis initiation as much as possible, but recognizing that adolescents will likely try cannabis or try alcohol or different substances like that, is to develop different methods of harm reduction strategies to really much like explain the impact of using cannabis. And I will discuss more on this in the coming slides. The determinant of cannabis use in youth were pretty much described in various publications, but this is mostly based on studies that investigated older adolescents. So again, 15 years of age. We have a publication with our colleague Bob Wellman, where we looked at whether these, some of these at least determinants of cannabis use that were identified in the literature from older adolescents were also related to initiation in younger. Okay? If you could just mute your microphone, thank you. Okay, so we identified, we verified that the determinants in older adolescents are very similar to what we have in younger adolescents, so people aged 12 to 14 years. So it seems to be rather consistent, although literature on the youngest adolescents are very scarce. There's not a lot on this subpopulation. So what are they? So first of all, people of male sex are more likely to initiate cannabis use and to initiate it early, although this gap between males and females appear to be decreasing with time. There's quite a bit of literature showing that people who identified as LGBTQ+ are more likely to use cannabis. There's an association between low SES and cannabis use, but also between having pocket money and using cannabis. And there's also an association between the use of other substances and cannabis. Now, maybe 10, 15 years ago, there was the gateway hypothesis that was postulated, and that was the idea that some substances were an entry to the use of other substances. That model is not that relevant anymore. There's no specific ordering in how people experience with substances, but there's a common finding to several studies that people tend to use a few substances together. As I said before, depressive symptoms and self-esteem are related to using cannabis, but also impulsivity. And people who are diagnosed with, I only have the acronym in front, TDAH, ADHD, thank you, are more likely to be to report using cannabis. Parental supervision and access at home are also related, obviously. And we all know this. We all know that adolescence is a period where friends become very much important in decision-making. And of course, friends who use cannabis is a known risk factors for cannabis use and cannabis initiation and use. Before I present the model we developed and the results that we obtained using the COMPASS study, I want to present the conceptual model that we use to frame our thinking about understanding why adolescents initiate cannabis use, and it's the theory of planned behavior. This is not a new theory. It's been around for quite a bit of time, but it's helpful in thinking about how someone starts developing a behavior. And before the behavior actually occurs and can be reported, there's the intention of initiating a behavior, and this would be initiating cannabis use in the context of our study. And according to this theory of planned behaviors, there are basically three reasons that underpin an intention to initiate a behavior. There's attitude. This is what people believe about cannabis. That would be the information that people have. That would be how people feel about using cannabis. For example, you could be someone who says, like, I am not going to initiate or to use any drugs. That could be like a belief or something that's important to you. So that would be part of attitude. There's subjective norms. This is how the others around you, the people who are important to you, whether they are friends, family, or perhaps even the social circles in which you are, how it influences what people think, how people feel about cannabis. And we know from different studies that since non-medical cannabis use was legalized in 2018, the norms, the social norms around cannabis have been changing. And the fact that it's now legal to buy cannabis in some age groups at least has made cannabis seen as a more of a normalized product, a bit like alcohol is. And finally, there are the perceived behavioral control. And these are separated between two groups, internal and external factors. And you can think about these as barriers and facilitators for a specific behavior. For example, we were going to talk about today, access to cannabis, whether it's around you, whether it's easy for you to get cannabis, would be considered an external factor. And we make the hypothesis that having friends who use cannabis increases access to cannabis because the product is around, but also you can perhaps share ways to get access to cannabis. And this is especially relevant because there are age restrictions on purchasing cannabis legally. So friends become a very important source of access to cannabis. So this is the objective of the first study I will present. It's a mediation model. So we're starting from knowledge that friends who use cannabis is a risk factor for initiation. And we're asking whether one important mechanism is access. So we're making the hypothesis that, as I said, friends who use cannabis will influence access, that will in turn influence the likelihood of initiating cannabis. But we're also postulating that this is not the only way through which friends can influence someone to start using cannabis, that there's also a direct effect. So that's the black arrow between the two blue variables. We use data from the COMPASS study. This is a very large data set that was initiated in 2012 and 13 in Ontario, and then it expanded to other provinces and territories. It's sampled, it's based on a sample of people or adolescents in grades 9 to 12 in high schools. It was extended to the Quebec City region a few years ago, and this is where Slim Haddad and Charles Bélanger were involved. And the data I'm presenting today is strictly from the Quebec schools, and that's because they had a special questionnaires about risk perception on cannabis that they developed and and presented in classroom in 2017. And that's why I'm only presenting findings from the Quebec region. Before the pandemic, data were collected through in-class questionnaires. Since then, they moved to online questionnaires, as many other studies. These are the four main questions that I will discuss today, and I will present later on the other covariates. Friends using cannabis was measured using a simple question: how much do your close friends smoke, consume cannabis? And we categorized it between none versus a few or more. Cannabis initiation was simply assessed by looking, let's say in 2017, and looking at that question here about the frequency of cannabis use. So in the past month, how often have you used marijuana or cannabis? And we define initiators as those who had said never, let's say in 2017, and switched to something else than never. So at least once in the following year in 2018, those were defined as initiators. The question about risk perception was a bit vague, let's say, but we used it nevertheless. And the question is, how much do you think a person who tries cannabis a few times is at risk to his or her physical or other health? So other health is not the most precise concept here, but it's really getting at risk for just trying cannabis and not risk for using cannabis on a regular basis. And finally, perceived access. And this is quite important. We are not measuring real access. We are measuring what people think their access would be. How hard or easy do you think it would be to get marijuana or cannabis if you wanted it? And we categorized it as difficult versus easy. That's actually how the variable was defined. There were not that many more than these two answers, except maybe there was the modality that said, I don't know. And I'll discuss that a bit later. It gave us quite a bit of headaches. Now, in a mediation study, it's quite important to consider the temporal ordering of notation of the different variables. And I'm going to present the notation in the same time. So technically speaking, it'd be better to have these variables measured not at the same time, because you want to allow the possibility for the exposure that's labeled A, friends who use cannabis, to be able to have an impact or affect the outcome, Y, initiating cannabis, as well as have an impact on the access of cannabis. In our case, we were not able to measure the exposure, friend use of cannabis, and access, the mediator, at different times. So they were measured at once in 2017. So everything I'm presenting today falls under the assumption that friends' use of cannabis impacts access to cannabis, but not the other way around. That access doesn't lead to having friends using cannabis. But as I will explain in details later, we are explicitly excluding people who have used cannabis in the past to investigate initiators. So in that context, it's likely that A's goes to M and not the other way around. Confounders were measured in 2016, so before all of these variables were measured, again, in order to try to avoid controlling for things that are on the causal pathway between the exposure mediators and the outcome. Now, here we use the natural effect models. I'm not going to go in details, but basically it's trying to understand or get from data the different potential outcomes. So this is the risk of initiating cannabis under observed exposure and mediators but also counterfactual, so alternative values for the exposure and the mediator. So we will estimate 3 different quantities. The first one is the total effect. This is the capturing the probability of initiating cannabis, that's the outcome. If you have friends, you use it versus if you don't. We will also estimate the natural indirect effect, and this is fixing the exposure to friends who use cannabis and change the value of the mediator to high access and low access and investigate how it's going to affect the probability of initiating cannabis. And there's a natural direct effect. So this is the arrow that goes from the exposure directly to the outcome. And here we fix the mediator accessibility, perceived access, to its potential value in adolescents who do not have friends who use cannabis, and see what the effect on the outcome is of varying the value of the exposure. So going from no friends who use versus having friends who use cannabis. Again, I'm not going to go in details here, but I want to say that we used a parametric regression-based causal mediation approach. So that means basically that we are fitting 2 models. The first one is the mediator model. Here we are regressing the mediator on the exposure as well as different confounders, potential confounders that I will explain in a minute. And we are also fitting an outcome model. This is the probability of initiating cannabis use in people who haven't yet. And this is including the mediator, M, as well as the exposure. And we can allow for an interaction term between the exposure and the mediator. Although in our model, it was very close to 0 and not significant, so we decided to exclude it. And once you have estimated those 2 models, they are feeding, the estimators are fed into the what is the nested counterfactual outcome probability. And this allows us to compute the risk difference for the natural direct effect, for the natural indirect effect, and the total effect, plus also estimating the quantity that matters the most in this study, which is the proportion of mediation. So what proportion of the association between having friends who use cannabis and initiating cannabis that, according to this model, is due to the increased access to cannabis use. And I should say that the reason why we use this model is that this is a model that does not require making the rare disease or the rare outcome assumption. The earlier models were making that assumption. In our case, the cumulative incidence of cannabis initiation is 14%, so it's not exactly rare. So this formula or this method allows us to get at exact estimates and prevent us, do not require us to make the rare disease assumption. There are several assumptions for the identification to be able to estimate the quantities we're interested in. I'm not going to talk about consistency or composition because they are very difficult or almost impossible to verify in the data, so you have to believe. But I will talk about the other 2, no interference. We're assuming that potential outcome are not affected by other individuals. When you're studying in adolescents, this is a tricky assumption to make because there is interdependence between individuals, but we'll have to make this assumption. And the last one is conditional ignorability. So basically, it's divided into 4 assumptions. So you don't want to have any confounding of the association between the exposure and the mediator and the outcome, and the exposure and the mediator. So I'm repeating 2 of the, sorry, there's a typo here, but all of the 3 arrows must not be confounded. But also, you have to make the assumption that none of the confounders of the association between the mediator and the outcome are affected by the exposure, because it would open another arrow and you wouldn't be able to really get at the impact of the mediator. And I will discuss this later on. So in the COMPASS study, we're lucky to have a long list of potential confounders that were measured. So we thought, we sat down and thought a lot hard and long about what should be included in the model. Remember that these are all measured before in 2016. So we're thinking that they're more likely to potentially cause or exposure, mediator, and outcome than the other way around. We have sociodemographics, age, sex, pocket money. We have the use of different substances, cigarette, vaping, alcohol, binge drinking, whether or not they're open to experimenting with tobacco products. There are quite a few variables measuring school life, time spent on homework, whether you are bullied or whether you are bullying others, whether the school has a substance ban policy, academic aspiration, and this variable that basically model the sense of belonging at school. And lifestyle variables, physical activity, organized sports, sedentary activity, other than homework. And the little asterisks here show variables that were included in the outcome model only. All the other variables were included both in the mediator and the outcome variable in the outcome model. Now, in terms of analytical strategy, we decided to work on the risk difference. It leads to easier interpretation in public health. And so that was relatively easy to do with the R package exact med that comes with the model that Geneviève Lefebvre and her team developed. We use multiple imputation to deal with missing values. We added more variables to try to make the imputation model better. We use inverse probability of censoring for attrition. Attrition was not that bad in our study because back then they were actually going to school in order to pass the questionnaires. So people were sitting in class, so they basically had to complete the questionnaire. And we only looked at age, sex, and school connectedness as factors to explain attrition. We performed quite a few sensitivity analysis, the first one being that we have 11 schools. And that's difficult because you know that you have to account for the fact that the sampling is done by school. So there's probably a clustering effect within schools. On the other hand, if you use a generalized estimating equation, you have like studies saying that 11 schools is a bit too small. You need to have many more clusters. And so there's a risk of type 1 error inflation. So in addition, what we decided to do is to adjust 4 schools as indicators in a regular regression. And as you'll see, it did not change the results much. Another thing that I alluded to earlier on is that for the question on access to cannabis, basically they were asked whether they felt like it would be easy to get cannabis. And the options were, it's going to be easy, it would be difficult, or I don't know. Now this I don't know variable was endorsed by 53% of people. That is quite a bit. And the problem is that it's unclear what it means. Does it mean I don't want to mention it? Does it mean I don't know because I never thought about it? So it's simply not something that I'm interested in. I'm not into cannabis. I don't know if I could get it. It probably contains some information. It probably says something about whether they feel it's easy or hard to have access, but we're not sure how to model it. So we did quite a few things. First of all, we imputed it. But the problem is when you impute it is that basically you're taking the distribution in the whole sample and in the people who know that it would be easy or hard to obtain cannabis. So it was an imputation that was did not vary much across people. We also looked at the literature on surveys, and there's a literature on how to deal with the DKs, the don't knows. I didn't know about this literature. I know about it now. And one of the things that people do is to say that people who respond don't know are probably sitting in the middle between finding it difficult or finding it easy to have access to cannabis. So what's suggested is to create this new modality that fits in the middle and try to model that. So we did that in two different ways. The first one is we use a linear model. So we sort of assume that the people who answered don't know would be really on the trend between the people who say it's easy and the people who say it's hard. And we also tried to say, okay, now we will not make any assumptions, and we'll use a multinomial model using the mediator as having three different categories. And again, as you'll see, the results did not change much. So I'm not gonna spend a lot of time on this, but this is basically the flow chart explaining how we started with 4,000 people and it ended up with less than 2,000. Basically, it was removing people who had already initiated cannabis, removing people who were in grade 10 and more, because we wanted to make sure to have long enough follow-up, because follow-up ends when high school ends. So we focused on the younger people in grades 7 to 9. There were roughly 500 people who were lost to follow-up. Most of them were included in the model for attrition, so we did not lose them. We used them in the analysis. And we ended up with 1,768 students who had not initiated cannabis in 2017 and were included in the analytical model. These are data that describe the analytical set. Interestingly, you see that we have a lot of people who are 12 to 14, and that's quite rare. It's difficult to find data on people this age, especially for cannabis, so that's quite interesting. Roughly 30% of them reported having at least one close friend who used cannabis. Most of them, at least 3/4 of them, thought it was easy to access cannabis. But again, this is among the 40-something people who did not say that they didn't know. So it's a bit skewed. 63% thought that cannabis was quite risky. And the 1-year cumulative incidence of cannabis use was 14%, as I said before. So I'm showing you now the results of the model. These are the risk difference. But I'd like to focus on the last row, which is the mediated proportion. So basically, what proportion of the association between having friends who use cannabis and initiating cannabis is explained, according to this model, by facilitating access to cannabis. So it oscillates between 35 to 53%. The 53% coming from the multinomial mediator model, the one where we're modeling the don't know as a separate category. So it's quite a good proportion. It's a good part. It's a good chunk of the association that, according to this model, would be explained by having access to cannabis. And you see that the risk difference, according to the model, is roughly 14%, and the risk difference for the total effect. And you see here too that using GLM, so using the schools as indicators, or using GE, using the schools as clusters, doesn't have a big effect. It has an impact, obviously, on the confidence interval, which is tighter for GE, but that was expected, but it doesn't change the message. So again, I want to bring back the assumptions that are underlying these results. So we have to assume that having friends who use cannabis causes easier access and not the other way around, but we thought that was pretty much likely. We did not include an interaction term, as I said, between the mediator and the exposure. We use different treatments for the don't know variable, or the don't know modality in the access variable, but results did not change much. We're pretty confident that, there might be residual confounding, obviously, but we adjusted for several of the variables that were important according to the literature. Now, the assumption that none of the confounders of the mediator and outcome, so confounders of the association between access and risk of initiating cannabis, are not affected by the fact that you have friends who use cannabis is a strong assumption to make, difficult to verify. And this is over 2 years. So there might be changes that we were not able to capture. That's a possibility that should be mentioned. Now, what are the implications of this results? First of all, it's difficult to think about, I don't know, parents of adolescents in the room or people who know adolescents. It's difficult to try to intervene on their friends. To tell someone, well, you shouldn't be friends with this person is something that's difficult. Intervening on access is obviously something that's possible, but it's difficult again because there's always like internet or different people around. So it's obviously like the SQDC is trying to monitor who buys cannabis in their store, but as you saw in the first slides, it's not doing that great. If roughly 15% of purchases in people aged 15 to 17 are done in the store. So it's difficult. And when you do a mediation study, we tend to focus on the indirect effect, the effect that's explained by the mediator. But here, there's the 60% of the association that is not explained by access. So what is in there? What explains the direct effect between having friends who use cannabis and initiating cannabis? I want to circle back to the idea of risk perception, right? So according to our model here for developing a behavior, there's always the attitude, what people feel or know or have as attitude towards cannabis. And perhaps the 60% is actually the risk perception that people have. Now, the problem with risk perception, it's something that might be easier to address. Like it's kind of natural for, I guess, us researchers to go and explain our findings, and cannabis is dangerous because of this and blah, 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 and hope that it will convince people that, you know, they shouldn't be using it or they should be careful or whatever. But there are two issues with working on risk perception. The first one, we try to consider it as a potential mediator. We try to model the fact that friends who are using cannabis could alter the perception of cannabis that people have, which will in turn make it more likely that people would initiate cannabis. And we ran the estimation, we ran the model, and the results are here. It's quite the definition of a null results, right? The indirect effect is 0.01, and the confidence interval pretty much includes the null. But it's very difficult to interpret these results because risk perceptions about cannabis could also influence who you are friends with. So this is where it's much more difficult to make the assumption that the arrow goes from the exposure to the mediator only. On top of that, and these are slides that a colleague of mine from France who studies prevention and health promotion in adolescents showed me, and these are models of how people think about how adolescents make different choices. The one on the right shows that it's thought that, you know, if you look at age, from age 5 to 30, the development of impulse control is much slower than the development of emotions. So according to this model, from the age of, let's say, 10 to 20, people are more driven by their emotion than impulse control. So you can talk about risk perception as much as you want. It's not clear that it's going to translate into different behaviors. The other graph is also a conceptual model that suggests that in adolescents, and these are the dotted line, compared to adults, there's a different subjective value that people put on positive versus negative effects. So it's thought that for adolescents, positive effects get a much bigger weight. The fact that, you know, you're gonna take cannabis, it's gonna give you a high, it's gonna be fun, you're gonna be with your friends, or you're gonna do some introspection or whatever, is given much more weight than the negative effects, which would be like perhaps like bad effects on your health or worse grades or whatever. So again, we can talk about perceptions, but this is a lens through which, according to this model, people are looking at the information they have. And we have to be careful about the impact we think that facts may have on people development of people behaviors. Okay, how am I doing for time?
Oh, 4:52.
Okay. Okay, good. So I'm just going to quickly present a prognostic tool that we developed for regular cannabis use. Again, this is done with a COMPASS study. And back then, the idea was that there are validated screening tools to identify people who have apparently problematic cannabis use. But what we wanted to do, and we couldn't find any, was to try to develop tools to somehow predict before people are developing problematic use, to predict or to identify who are the adolescents at risk of developing regular use, which we defined as weekly use. And this is a key milestone in the natural course of problematic cannabis use. Obviously, not all people who use weekly will develop a problematic use, but it's an indicator. And the idea here was to have some sort of a decision tool that could be used by health professionals in order to decide to screen for who they would intervene with. And again, we use the COMPASS data. I'm not going to go into the details here, but we had a training sample to develop our prediction model. We had a temporal validation sample to see if the model would still be performing well a year later in similar data. And we compared Ontario with Quebec to do geographical validation. And we had access to 45 predictors, some of which I described earlier, in addition to mental health variables. And again, we were looking at predictors at a given year, trying to predict initiation of going through regular cannabis use and non-regular cannabis users a year after. So we had this temporality working out for us here. And we use what's called the lasso algorithm. So basically, it's a mix between lasso for selecting variables and bootstrap to try to have a some consistent set of predictors and it's particularly helpful when predictors are correlated amongst themselves. And I'm just going to present what we got, and then, because I'm more interested in the discussion afterwards, but basically out of the 45 predictors in a COMPASS study, the ones that were pretty robust was male sex and age, years since first use of cannabis. So if you had started cannabis earlier in your life, you were more likely to become a regular user. So that's to be expected. Perceived ease of obtaining cannabis, or here again, this idea of access. And then 3 other variables that were related to substance use: ever smoked cigarettes, ever used e-cigarettes, and mixing alcohol with energy drink, as well as failing math or English French classes. So these were the predictors. The C-statistics 1.02. And I have to mention here that in working on this model, we decided that we wanted the sensitivity to be at least 80%. And we let the specificity be maximized, constraining the sensitivity to 0.8, and it was 0.69. So given that this is a behavior and it's not like a medical diagnosis, these numbers are relatively good in terms of performance. And now in terms of discussion, the selected predictors, we had substance use, so that's in accordance to the literature. We know that using substance is a good predictors of using a different substance. There were no mental or physical health predictors that were selected. That's quite interesting. The model was developed mostly on males because we had more males using cannabis, but it seemed to perform well on females as well. The idea was that this model could help identify who was at risk in order to get more counseling. And it was felt that it could be a complementary strategy in order to try to get, again, the conversation going. But before I finish my talk, I just want to talk about the reaction that people have to these tools. So in 2018, we published a similar tool, but this time it was for cigarette smoking initiation in youth. And when we published this in Pediatrics, the editor, which is who is Jonathan Klein, wrote an editorial on our paper, and it was quite critical, but I think the criticisms were fair and were important. So I want to mention it. And the first criticism he had, according for this tool, was that we were saying that basically developing such decision-making tool is helpful when you have limited resources, and that you cannot do counseling on all of the people you see in an office. And it was like, he didn't buy that. He said that there's no evidence that reveals that counseling all patients is not feasible. I don't know. Like, to me, it seems that every time I see a doctor, everything seems to be time constrained. So I'm not that sure about that first criticism, but it's true. And we have this push and pull in public health. Like, should we go universal or should we go targeted? That's always important. Then he said that some predictors are risk behavior. And that's the case also in our cannabis model. And that instead of using some predictors to predict the development of other behaviors, we should always do a wider health risk appraisal and discuss everything all at once, which is, again, quite possible. However, the opposite is sometimes happening. We're not questioning, we're not discussing anything instead of discussing specific things. And he said also that specific items were nearly as sensitive and specific as the entire tool. And that's quite a fair criticism as well. But then what I want to say, and I think that the goal of these tools should be, is really to get the conversation going. Because right now, I think that many of the conversations that health professionals could have about substance use with adolescents are simply swept under the rug because there's no time. Now, to me, it doesn't really matter if you use a tool or if you just do a general appraisal. These must be discussed in order to try to get at specific interventions that could be done. So in conclusion, I think cannabis use in youth is an important public health issue. Friends who use cannabis is an important driver for cannabis initiation. Access to cannabis may explain up to 40% of the mechanisms linking friends who use cannabis and initiation. Acting on access to cannabis may be challenging. Acting on perception may be more feasible, but the impacts are uncertain. And prognostic tools to identify youth at risk of regular cannabis use may help, but what truly matters is to get a conversation going. So that concludes my talk. Thank you. And this is a link to the selfie groups to which I belong. And we're doing life course studies, especially on youth and young adults. Thank you.
Great, thank you very much. We don't really have time for question, but if there is any question or two from the venue, otherwise, hold on, I'm just gonna check Zoom. There is no question.
There's a question over here.
Oh, awesome. Okay, please go ahead. We can hear you. Suzanne?
Yeah, it's Kaberi Descripta. I have a question. Thank you, Marie-Pierre, for a really nice talk. And I really like the prognostic school and the association with friends. My question is about the mediation variable, because I can't really think of a circumstance where you would have friends who use cannabis and not have better access to cannabis. So I don't know what the variability there would be in that relationship. So that seems a little bit odd to me. And then the second is, even though it's quite elegant how you went about it, I wonder about the variation in that relationship. And then the second thing is, is there any scope to actually speak to any of these kids to understand if friends are facilitating the access or if that is a big driver? Because I think that would be an important complementary thing to look at.
Yeah, thank you. That's a great question. I'll answer the second one first. To my knowledge, there hasn't been any qualitative discussion or studies within the Compass study. I could be wrong, but we didn't have access to the adolescents. We're now probably getting close to 18. The first question is quite important. Variability, it was there because so many people, or 53 people, said that they didn't know whether they had access to cannabis. And I think that in high school, there's a possibility for people to be friends at the school. Like you mix with people, you consider them friends, but you might not see them necessarily outside of class. And I think that's at least one possibility for people to have friends who use cannabis without necessarily going to parties or going to events where you have access to cannabis. So I think it's possible, but it's definitely a good question. Yeah.
And I guess just a quick second question, in terms of the well, not a question, just a comment. For the counseling, I am a physician. I wouldn't say put it in the hands of physicians. There's guidance counselors and other people at the schools. So I think that's probably a better route to go.
Yeah. It's just the confidentiality that's a bit problematic at school, where I think it's much better in the hands of physicians, but there are lots of barriers. I agree. That's a good comment.
Thanks.
I have a quick question too for prognostic model. So the specificity was like 0.69.
Yes.
So there would be a fair number of false positives.
Yes.
Now, if recommendation for counseling from stigmatization perspective is done like secret to the high-risk children, because they almost need profiling.
Yeah.
So that gets to a bit of ethics issue. So because you are essentially telling me, you will be high risk, or you are high risk of this and that. So how do you deliver? Because you mentioned one barrier is resource intense, which is already barrier for low specificity. But more important is how do you deliver your intervention without stigmatizing children, number one. Number two, I forgot.
No, number one's a good question.
Number one was
it's definitely important. When we decided to focus on sensitivity, it's because we felt that it was not an intervention that was invasive or could do harm. And again, we designed it as something that would be done in an office without a parent, without friends. And so we felt that, being misidentified as somebody who's at risk was not the biggest problem. The biggest problem was really to miss someone who needed it. Because we thought that having a conversation about substances would be a good thing regardless. So that was the thinking. It can be debated, and again, some people say that this conversation should be happening regardless of whether the person is identified as at risk or not. But that was our thinking behind that.
Yes, but I think that has to be discussed with school. Number two, I remember now. So essentially, you will have 31% of children plus parents will be mislabeled. Positive. So how do you keep their trust? Because they are essentially telling again, you are high risk. So we will start conversation. But then later you would say, oh, actually you're not high risk. Sorry.
I don't think, I don't know how doctors would do it, but I don't think it'd be going like, oh, you are at risk. I think it would be just a signal that they should have a conversation about substances with a person. But then somebody could say, well, ask if the kid is using substances, and if they are already, have the conversation. So, you know, I get this, but the goal would not be to put a label on a person. Absolutely not. That would be detrimental. For sure.
Yes, okay. I think there are a couple of questions from so there is a
is having friends who use cannabis considered as standalone entity, or does it go hand in hand with peer pressure to use cannabis for those who have not yet tried it or who do not use it? That's a very good question. We did not have any data on peer pressure. It's clearly something that's important in this age group. But interestingly, you know, peer pressure is also something that's important later on. We found in another study that a lot of people were using cannabis during the pandemics to bond with their spouse. So it's, you know, there was this idea that, you know, it's not the same type of peer pressure, but regardless, like what others are doing is important in figuring out what you're going to do. But we didn't have to answer this specific question. No, it's not something we can do with the data. We're not able to address that question or to isolate one from the other.
Thank you.
Yeah,
I think we have one other question. I'd like to have your thoughts about the role of pre-existing or coexisting mental or behavioral problem in the mediation analysis.
Right. We are asking people to self-report diagnosis of mental health conditions. Self-reports are not the ideal way to measure this. For example, for ADHD, we are asking about self-report for ADHD, but also self-report of using medication, and there's no perfect match between the two. So in this age group, I think probably a lot of disorders might still go underdiagnosed. And the mental health variables most of them were not available as potential confounders in 2016. They were measured later on at the same time as the mediator. So that was problematic. We tried to do some sensitivity analysis. It did not change the results much, but I wouldn't say that our dealing with the mental health variables or pre-baseline or baseline diagnosis is ideal. I mean, it could be a residual confounder for sure.
Awesome. Thank you.
Yeah. Thank you.
Any more questions? If not, thank you very much again for interesting talk.